Hello, this is part 7B, the procedures of the upper extremity. We're going to begin with the wrist now. On the wrist, we're going to take a look at the PA, the lateral oblique, the lateral projection, the PA ulnar deviation, the PA axial Stetcher method, and then the tangential carpal canal gainer heart method. The patient must be seated when we're performing images of the wrist so that we're going to have the axilla in contact with the table, or we're going to elevate the extremity to the shoulder level on a suitable support. We want to make sure that the shoulder, the elbow, and the wrist are all in the same plane. We're going to collimate down to 2.5 inches proximal and distal to the wrist joint and 1 inch on the sides for all images of the wrist. So let's begin with looking at the PA or the AP projection of the wrist. For the PA projection, we're going to have the hand and the wrist resting on the image receptor. We're going to have the hand resting the forearm on the table with the palm side down. We're going to slightly arch the hand at the metacarpophalangeal joints by flexing the digits, and that places the wrist in close contact with the image receptor. When necessary, we can place the support under the digits to immobilize them. If you perform an AP projection, which is shown below, then that would be to supinate the hand, extend the fingers to demonstrate the carpal interspaces better. So notice that the hand is on a sponge in this case. Either case, we're going to center perpendicular to the mid-carpals, and we already talked about the collimation. Structure is shown. We're going to see a PA projection of the carpals, the distal radius and ulna, and the proximal metacarpals. We're going to see a little bit of an oblique rotation to the ulna, and when the ulna is under examination, an AP projection should be taken. This is the image of the PA projection of the wrist, showing the metacarpals as well as the carpals, and then the distal radius and ulna. So we're looking at the distal radius and ulna of the carpals and the proximal half of the metacarpals. No flexion of the digits to overlap. No rotation of the carpals, metacarpals, radius, and ulna. And we have an open radial ulnar joint space, which is important too. Now, for performing an AP projection of the wrist, the reason why would be that your carpal interspaces are better visualized than in the PA projection. So that's the only reason why the AP projection would be performed. In addition to that would be if you wanted to see the ulna too. It would be better visualized. If we're going to perform a PA, a lateral oblique projection of the wrist, we're going to rotate the wrist laterally from the PA projection 45 degrees. We're going to extend the wrist slightly, and it helps to use a sponge for this so the patient doesn't have to hold their wrist in position. If the scaphoid's under examination, adjust the wrist and ulnar deviation, and you can place a sandbag across the forearm. We're going to be perpendicular to the metacarpals, and as we talked about before, the collimation is going to be the same as it was for the PA. And we're going to see the carpals on the lateral side of the wrist. Specifically, those bones on the lateral side, those carpals, are the trapezium and the scaphoid. The scaphoid is really important because it's the most commonly fractured carpal bone, and that's why it's so important to see. So here we go. So there is superimposition of the scaphoid, but we can visualize it. So there's the scaphoid that's visualized here. And then we can also see the trapezium visualized here. So we're looking at a 45-degree rotation. We want to see the carpals on the lateral side of the wrist. The trapezium should be seen in the distal half of the scaphoid without superimposition. The lateral projection, we're going to do a lateral to medial because it is much more comfortable for the patient. We're going to make sure that we bend the elbow 90 degrees is what we're going to make sure that we have. And so that elbow's at a perfect 90 degrees, plus the wrist is in a true lateral projection. We want to make sure that we have the humeral epicondyles and stellate processes superimposed and perpendicular to the image receptor. The wrist is in a true lateral position. We want to be perpendicular to the mid-carpal, so we want that collimation to be the same as it was for the PA as well as for the oblique. We're going to get a lot of projection of the proximal metacarpals, the carpals, and the distal radius and ulna. And we're going to see this obtained with the radial surface against the image receptor could be shown in comparison, but it can be shown, we can also look at with this, looking at anterior or posterior displacement with fractures is very important, just like you have with the lateral projection of the hand. So looking at the image, we're concerned about the distal radius and ulna being overlapped, the superimposition being there, and the superimposition of the metacarpals as well. The PA projection with ulnar deviation, the purpose is for a scaphoid fracture or fracture of the scaphoid. So we want the elbow to still be at a 90-degree angle. We want the wrist on the image receptor for that PA projection without moving the forearm. We turn the hand outward so that the wrist is an extreme ulnar deviation. We want to be perpendicular to the scaphoid bone is the idea because we're looking for a scaphoid fracture. And then Merrill's does talk about how we could use a CR angulation of 10 to 15 degrees proximally. We're going to use the same collimation that we've talked about previously, and we're going to look at decreasing foreshortening of the scaphoid bone. It also opens the spaces between the adjacent carpals of the skin next to the scaphoid. So here we go. And there's the scaphoid, the joint. The idea is to desuperimpose it so we can see fractures. Now this is not exactly the most comfortable position. So for performing this, this is something that the patient may not be able to perform it, which is why we have another option. But if they can perform it, then we can get almost maximum ulnar deviation as much as possible. The PA axial projection Stetcher method is used in case the patient cannot do an ulnar deviation. If the patient is seated at the end of the table and we rest the forearm on the table, we have 1 to 2 methods that we can do. We can either elevate the image receptor 20 degrees or we can angle the central ray 20 degrees toward the elbow. Either case, we're going to center perpendicular to the table and the scaphoid, and we're going to do the same collimation we did on all the other projections of the wrist. So taking a look at the two options, we can either have the sponge right directly beneath the image receptor, the 20-degree sponge, or we can angle 20 degrees toward the elbow. In either case, we're going to have that opening of the articulations of the scaphoid are open and there's no foreshortening of the scaphoid. We're able to visualize it on the image. The last image of the wrist can be performed 2 ways. It can be done with an inferior superior or superior inferior. We'll take a look at this one first. This one's called the Gainer Hart method. It's where we're looking at the carpal canal, which is the sulcus, and we're looking for carpal tunnel syndrome as an issue. We could also demonstrate fractures of the hamate, the pisiform, and the trapezium on this image. Now this particular position is an inferior superior position because we're going from the distal parts of the fingers of the hand to the more superior aspect. So we're going to hyperextend the wrist. We're going to center at the level of the radial styloid process, adjust the hand to make sure it's as vertical as much as possible. And we're going to make sure that to avoid superimposition, rotate the hand slightly toward the radial side. So we're going to slightly rotate toward the radial side. Have the patient grasp the other digits with the opposite hand or use a device such as shown here to hold the wrist in extended position. And this is a great tool to use, just using tape or to use Velcro. We're going to center to the base of the third metacarpal, angle 25 to 30 degrees to the long axis of the hand. We're going to adjust the radiation field to 1 inch on all three sides of the shadow of the wrist. And we're going to be able to see the carpal canal, the bones, and the polar aspect of the trapezium. We're going to see the tubercle of the trapezium and the scaphoid, the capitate, the hook of the hamate, which is called the hamulus, the triquetrum, and the entire pisiform is completely desuperimposed. So let's take a look. And here we go. So we're able to see there's that pisiform that we were just talking about, completely desuperimposed, and there's the hamulus of the hamate that we spoke about. Here's the scaphoid. the trapezium, the trapezoid, and the lunate. Those are superimposed, however. But we're looking at the canal. The carpals are in an arch arrangement, and we're able to see surrounding soft tissues. Now, in the superior inferior position, we're going to do the structures are the same, but we're going to do a little bit different positioning. We're going to have the patient dorsiflex the wrist as much as possible, and then have them lean so that they have their palm of their hand on the image receptor. So this is used when a patient cannot assume the previously shown position. So we're going to do it. This is going to be a tangential projection again to the carpal canal at the level of the midpoint of the wrist. And we're going to include the palmar aspect of the wrist and proximal 1/3 of the metacarpals and 1 inch on all sides. And here's the superior inferior position, the image, and there's the pisiform that's shown in profile. Okay, so next we're going to take a look at the forearm. With the forearm, we are looking at room prep, just being and patient prep, having no artifacts or anything. Give patients their instruction. Have always had paperwork ready and collimation, close collimation, ID markers all the time. We don't do any type of respiratory instructions for anything with the elbow or the forearm at all. It's only for the humerus, and we're going to always use 40-inch SID. And of course, we always protect our patient with lead aprons. So we're going to do two projections. We're going to do an AP projection and a lateral projection of the forearm. We want to make sure that we supinate the hand for the forearm and not pronate it. So for the AP projection of the forearm, we're going to have the person in an anatomic position, which means we're going to supinate the hand, extend the elbow, place the dorsal surface of the forearm against the image receptor. We want the long axis of the image receptor parallel with the forearm, and we want them to lean laterally until the forearm is in a true supinated position. You want to palpate and adjust the humeral epicondyles to be equidistant from the image receptor because they should be parallel with the image receptor. We want to be perpendicular to the midpoint of the forearm, and we want to adjust the size of the image of the field so it's 2 inches distal to the wrist and 1 inch on the elbow and 1 inch on the sides. So you want to see the elbow and the wrist joints, but also the entire radius and ulna should be desuperimposed at the bodies. So the entire forearm, including the wrist and the distal humerus, should be shown. Slight superimposition of the radial neck, the head, and the tuberosity over the proximal ulna. We should see no elongation or foreshortening of the humeral epicondyles. They should be parallel to the image receptor. We should have an open elbow joint if the shoulder was placed in the same plane as the forearm in an open radio-ulnar space. In the lateral projection of the forearm, this is very similar to what we had with the wrist, in that we're going to flex the elbow to 90 degrees. We always want to make sure that the humerus and the forearm are in the same plane. We want to also ensure that the humeral epicondyles are superimposed and are perpendicular to the image receptor. The thumb side of the hand should be up. So we're going to be perpendicular to the midpoint of the forearm, just as we did for the AP projection. We're going to do the same collimation that we did for the AP projection, and we pretty much see the same structure shown, except for now we're in a lateral projection. We see the elbow joint, the radius and ulna, and then the superimposed row of the carpal bones. And here we go. So we're going to see that we've got this, the proper collimation. We've got the 90-degree angulation that is shown here. We're going to see superimposition of the radius and ulna at their distal end. So they definitely should be superimposed. We should see the radial head over the coronoid process. And I forgot to fill this in, sorry. The radial tuberosity should be facing anteriorly, is what the blank should be here, anteriorly. We should have superimposed humeral epicondyles, and the elbow should be flexed, as I said before, 90 degrees. With the elbow, we're going to look at the AP, the lateral oblique, the medial oblique, AP partial flexion, and the trauma axial laterals called the coil method. For the elbow, we're going to do the AP projection first. With the AP projection, this is just a lot like the AP projection of the forearm, except we're going to center over the elbow this time. We're going to extend the elbow, supinate the hand, and center to the elbow joint. We want to make sure that the image receptor is parallel with the long axis of the part, and we want to make sure that the humeral epicondyles are parallel with the plane of the image receptor. So they should be parallel with the plane of the image receptor. We want to center perpendicular to the elbow joint, and we want to adjust the field so we have 3 inches proximally and distally, and 1 inch on the sides in this case. So we want to see an AP projection of the elbow joint, the distal arm, and the proximal forearm. And so looking at our AP projection, we're going to notice that the medial epicondyle does protrude more than the lateral because it is larger, and that there is overlap definitely of the radius and ulna at the proximal end. The elbow joint should be centered in the exposure field, and we should have an open humeroradial joint. So that joint should be open. There should be no rotation of the humeral epicondyles. They should be parallel with the image receptor. On the lateral projection of the elbow, this is just like the wrist and the forearm in that we're going to make sure that our humerus and our forearm are in the same plane and that we have a 90-degree angle that's formed. We're going to make sure that we center to the elbow joint, and we're going to ensure that also the humeral epicondyles are again perpendicular to the plane of the image receptor. We're going to be perpendicular to the elbow joint. We're going to use the same collimation as we did for the AP, and that we've got 3 inches proximal and distal to the elbow joint. We can go 1 inch on each side. And then we've got the elbow joint, the distal forearm, and the a distal arm and the proximal forearm. And looking at our image, we've got our image is showing what we've got the 90-degree angle. The olecranon process is in profile. We can see that the radial head is partially superimposed over the coronoid process. We can see the radial neck is shown. The radial tuberosity is facing anteriorly. On the AP oblique projection medial rotation, we're going to medially rotate the patient from the AP projection 45 degrees. So we want the humeral epicondyles 45 degrees from the true anatomic position. This is going to clear the coronoid process from the radial head, and that's the purpose of this one, is to look at the coronoid process. We want to be perpendicular to the elbow joint. We want to again have 3 inches proximally and distally, but 1 inch is a collimation on both sides. And we want to see the coronoid process free of superimposition. So we're looking here at the bunny view. So in the bunny view, here's the mouth of the bunny down here is open. Here's the nose of the bunny. I guess we could make our own little ears up here. And there's the eye of the bunny. So anyway, the lower open mouth part of the mouth is the coronoid process. So the coronoid process is in profile. We have an elongated medial epicondyle, and our ulna is superimposed by the radial head and neck. And we can visualize the trochlea, shown here. Now on the AP oblique projection lateral rotation, from the AP projection, we're going to laterally rotate the elbow 45 degrees. We're going to center to the elbow joint. We're going to adjust our field 3 inches proximally and distally, and 1 inch collimation on the sides. We're going to do an oblique projection of the elbow with the radial head and neck free of superimposition of the ulna. Now this oblique is more commonly performed. It's going to show us, as visualized here, the radial head, the neck, and the tuberosity. All of those are free of superimposition of the ulna. And we see an elongated lateral epicondyle. Here's the capitulum, and there is the elongated lateral epicondyle. Now, if a patient is unable to straighten their arm for an AP projection, we do have a trauma method for this. This would be called partial flexion. In partial flexion, we're going to do two projections. One is of the distal humerus and one is of the proximal forearms. This is of the distal humerus. So we're going to have the patient place their humerus in the same plane as the image receptor, if possible supinate the hand, but we're going to have the humerus on the image receptor, noticing that we can angle distally into the joint possibly if you wanted to, but we're going to do 3 inches proximal and distal to the elbow joint and 1 inches on each side. And we're looking at the distal humerus when the elbow cannot be fully extended. We're looking here at the AP projection then of the distal humerus is the goal without a distortion or any type of rotation. We do have a closed elbow joint because we did not completely extend the elbow. On the partial flexion, which is the second view, we're going to do the proximal forearm. So this time the proximal forearm's in the image receptor. The patient may have to stand in order for this one to be performed, but we're going to perform it so that we're going to be perpendicular to the elbow joint and the long axis of the forearm. We're going to make sure that the central ray passes through its midpoint. We want to still have 3 inches proximal and distal to the elbow joint and 1 inches on the sides. And we're looking here at the proximal forearm when the elbow cannot be fully extended. So this is still part of that trauma routine. And here we are. So we're looking here at the proximal forearm. The technique wasn't the best here, but we're looking at a partially open elbow joint. Now there are two projections that can be performed in place of the obliques. So these are for the axiolateral projections are the coil method. Now this is a seated position. We're going to start off with this top one with letter A. We're going to pronate the hand. The patient seated at the end of the table. The elbow is going to be flexed 90 degrees with the hand is pronated. And we're going to then angle the tube 45 degrees toward the shoulder. And that is the coil method in order to visualize the radial head and the capitulum. That is the purpose. On the other hand, if we were to look at flexing the elbow instead 80 degrees, which would be the second one, we're going to direct the centroid now 45 degrees away from the shoulder, which is what is shown here. And we're going to visualize the coronoid process and the trochlea now instead. We're going to, for both of these, we're going to enter at the mid elbow and we're going to adjust 3 inches proximally and distally to the elbow joint for both projections. The top image is the first one where we had the 90-degree angle of the arm and the 45-degree angle of the tube toward the shoulder is going to demonstrate the radial head and the neck. This is in place of the external oblique. On the coronoid process, or the view showing the coronoid process, which is shown here, this was with the elbow flex 80 degrees, and now we're doing this in place of the AP oblique medial rotation. And here's the coil method for the radial head, showing that you could technically, with the patient seated, or you could position with them lying down, but you're just going to see that radial head and the neck and the tuberosity. And the coronoid process, we're going to do this at an 80-degree angle. You could technically perform this also with the patient recumbent if they're unable to stand, and we're going to see the coronoid process. And these are both called the coil method, and again, they're from trauma. The last thing in this chapter is looking at the humerus. We have the AP, the lateral, the neutral, and the transthoracic lateral. We're going to be focusing on the AP and the lateral because the neutral and the transthoracic lateral are in the next chapter. The AP and the lateral are performed for non-trauma. The neutral and the transthoracic lateral are for trauma only. So we'll take a look at those specifically in the next chapter, like I already said. So here's the AP projection of the humerus. We're going to prefer this to be performed upright just for patient comfort. Unless the patient cannot stand, we'll go do the supine. We want to make sure that the upper margin of the image receptor is approximately 1.5 inches above the humeral head. We want to abduct the arm slightly. We want to supinate the hand unless contraindicated due to trauma. If that would be the case, that would be a neutral instead. And you want the epicondyles to be parallel with the image receptor, something very important. That's the same thing as we have with the elbow and also with the forearm for the AP projection. We want to suspend respiration for this. We're going to be perpendicular to the midpoint of the humerus in the center of the image receptor. We want the radiation field to be 2 inches distal to the elbow joint and superior to the shoulder, and just 1 inch on each side. So we're going to collimate down as much as possible. And we're going to see the AP projection where we have the proper position of the epicondyles visualized. So here we go. So the epicondyles should be parallel to the image receptor, which they are in this case. And we're going to see the greater tubercle in profile is the goal. And so we're going to be able to visualize the entire humerus with the body in the center. And then we have the lateral projection, which again would be performed either medial lateral or lateral to medial. The top image we're looking at is lateral to medial, so we'll start off there. So lateral to medial, we're going to have the patient upright if at all possible, but the lateral to medial, this is the lateral surface of the person's arm, and we're going to go in medially. So this one is more difficult to do, but the patient's going to internally rotate their arm, flex the elbow approximately 90 degrees, and put their anterior hand on their hip. This could be called the sassy method. So the patient's putting their back of the hand on their hip. So the coronal planes passing through the epicondyle should be perpendicular to the plane of the image receptor. So they need to be able to bend their elbow and get those epicondyles perpendicular to the image receptor plane. Something that's a little bit less painful and less if are uncomfortable for a person who has a fracture is a medial to lateral. This one down here is the medial to lateral. You're going to use this for a patient facing toward the image receptor. They're slightly oblique in this case, and they're going to, if they're holding their hand, have the patient hold their hand if not, and they're going to move the elbows of the humerus so that you can see it as shown in the image shown. So we're going to perform this on respiration on suspension. We're going to be perpendicular to the midpoint of the humerus, and we're going to have our image receptor so it's collimation open 2 inches distal to the elbow joint and to the superior shoulder and 1 inch on the sides. And we're going to see a true lateral projection of the entire humerus. So taking a look at the image shown here, we want to see the lesser trochanter tubercle in profile. It'll be superimposed over the scapula, but it's still in profile. And then we have the epicondyles should be superimposed, and we should be able to see the olecranon process as well. And that concludes our lesson on the upper extremity.